Okay, so now we're going to do the other half, the lower respiratory disorders in chapter 41. Your chapter begins with talking about the chronic obstructive pulmonary diseases, which I think you might be doing in your med-surg class right about now. I was trying to time them as close together as possible. So you have asthma, which is a reversible airway restriction where the rest are not reversible. So bronchiectasis, there's an abnormal dilation of the bronchi and bronchioles because they have frequent infections. I've seen bronchiectasis more often in like a child. Bronchitis can become a chronic bronchitis where it's progressive, caused by smoking or some other lung infection, or even just frequent problems due to allergies, due to other things. And then COPD includes that chronic bronchitis and emphysema where they're chronically obstructed. There's a little chart about bronchial asthma that you'll find in your chart on the bottom of in your book text on the bottom page 585. I felt it was important to include this, bring your attention to it, because if you look at the different irritants that are affecting the airway into the lung, what your body's response is when you look right to this box right here, and then the further response here, and then you can think about why you would give whatever medications you would give and why they would have whatever symptoms they have. Probably getting sick of this autonomic nervous system. Here we are back to the adrenergic agonists, which is your sympathetic nervous system. Remember the right side of that chart. Okay, sorry. Put on here your C-amp, which your text mentioned several times, which helps to maintain that bronchodilation. And that is triggered by these adrenergic agonists. Which ones stop it, which ones inhibit it, which ones promote it. And here we go with the sympathomimetics or adrenergics. We're looking at beta-2 agonists, or exanon mimics the beta-2 response. Remember, you have two lungs. Then sometimes you'll lose anticholinergics because it'll be the opposite effect of the adrenergics. You have a chart in your text or table 41.1 where it breaks down which ones are alpha and beta, which ones are beta only. You see the majority of them are beta adrenergics. These ones that are select beta-2 are specifically to have the lung response. Mentioned in previous lecture about albuterol, because it's a beta-2, selective beta-2 receptor agonist for the bronchodilation. It's recommended to do slow, deep breaths and hold it in for 5 to 10 seconds when they use this. Onset is within 1 to 5 minutes. It peaks in 15 to 30 minutes, lasts for several hours. It's poorly absorbed by the GI tract, so it's preferable to be given in an inhaler. It does actually come in liquid form, and occasionally I've had to prescribe that to young children. It just doesn't work as well. It's best if you can get it inhaled in some form. It shows it on your, it is. It's in your text, that table 41.1. It shows you some of the PO route and the slow release, different things. Side effects, remember the beta response, so tremulous, muscle cramps, tachycardia. Usually that does not last very long. Go to the next slide. These are selective beta-2 long-acting, Salmeterol for Moderol. Why would you have, now think of the difference between the two. The first one, I'm going to go back. When you have these selective beta-2 agonists, these are short-acting. They only last maybe 4 to 6 hours. They kick in within a couple of minutes. So those are what you call your rescue inhalers. You get to these long-acting, these are to be used on a regular basis. This is the one you want the patient using twice a day, at least once a day, but see here, duration of action 12 hours or more. So preferably getting the person to use this twice a day on a regular basis to maintain that bronchodilation for that chronic asthma person. If they're young and they're playing sports, you have them do it twice a day, carry their rescue inhaler for their breakthrough moments, or if it's exercise induced, they'll just use the short-acting ones. And not recommended as a sole therapy for asthma. There's multiple factors triggering asthma, so other medicines can get added in, and that's beyond what you need to know at this point. Non-selective beta agonists. These were mentioned in a previous lecture talking about the epinephrine. I don't think we talked about isoproterenol. These medicines are given subcutaneously or intramuscularly. Epinephrine has a very rapid onset and a very short duration. Some people give it subcutaneously during an asthma attack, which that if given, it'll take 5 to 10 minutes to relieve. I've never administered it that way. I know it can be. Now, those you want to be careful or to give this to are people with cardiovascular disease, hypertension, diabetes, hyperthyroid. Just think back to those non-selective beta agonists. So they're going to hit the beta-1 and the beta-2. And that's your heart and your lungs and your bladder, the renal. Anticholinergics. Now this begins on page 588 where it discusses the anticholinergics. There is a table, 41.1, gives you the names of them, which is on your next slide. We're going to a little more. And anticholinergic, so it is against the parasympathetic, so you can figure out the symptoms that go there. Remember the I cannot eat, cannot sleep, can't pee, can't see, can't eat. Okay. Here are some of the specifics that are listed also in your text. I just gave you some pictures here. If you've not seen Spiriva, most of the patients have it in this form here where you put the little capsule in. It's once a day. This top closes down. They put it in their mouth and suck it in. And they have to rinse that. It's called a handyhaler. And they have to wash it with warm water. The ipratropium bromide was I mentioned in previous lecture. It's used to treat asthma because it dilates the bronchioles. Combivent is the combination of the ipratropium and albuterol because they work in two different fashions in the lungs. The ipratropium is working as an anticholinergic where the albuterol is the beta-2 selective. Spiriva is used for that chronic COPD. They use it on a daily basis. Methylxanthine derivatives, the most common one you're going to see is theophylline. That's why I listed the theophylline here. I think it's in your text. You find it. Theophylline preparations or aminophylline, table 41.3 on page 590. That's the one you should pay attention to. Not used as much as it used to be. It used to be used quite often. It'll be used in the hospital with an IV infusion, trying to get them to that therapeutic. And you can see all the contraindications. It increases that C-AMP, remember, cyclic adenosine monophosphate, which helps to maintain bronchodilation. So the purpose of this is to keep those bronchioles dilated. You can see the numerous side effects. Those are very common with it. The tachycardia is very much the nervousness, irritability, all the way to this cardiorespiratory collapse. It also has multiple drug interactions. It can't, and with erythromycin, cimetidine, which is Tagamet, which everything reacts to. Can't use it if they have cirrhosis, congestive heart failure, pulmonary edema. All these things can cause increased half-life, problems, if trouble clearing it from your body if you're a cigarette smoker, on contraceptives, on phenytoin, which is Dilantin. It can be toxic. Your therapeutic range, you can see here, your range is pretty narrow, so you do have to draw drug levels. This one doesn't have a peak and a trough, it just has a drug level. And greater than 20, if you do reach toxicity, it can lead to headaches, palpitations, dizziness, severe restlessness. All the way greater than 20 can lead to local and generalized seizures and sudden death. That's why it's not used as often. We're getting near the end. Your leukotriene receptor antagonist. This starts on page 590. Remember, antagonist, it goes against it. Leukotriene is a chemical mediator that can cause inflammatory changes in the lungs, increases mucus production, airway wall edema, which leads to the bronchoconstriction, often found in those with asthma. So the leukotriene receptor agonist is to not let that receptor find that site to stop that, will block that reaction. It's not for acute treatment, it is to prevent this progression. The one you will see the most, I was looking for a new text table, 41.1. It talks about the leukotriene modifiers. Then the second one, monticulist or singular, is the one you're going to see most often. It's a prototype drug chart somewhere. I'm not sure where that is in this book. Okay. The effect, the other one, Xyluten, is not used very often because it's required to take 4 times a day, and the other, this first one, Zafarculest, is required twice a day. You will learn that the more times a day somebody has to take a medicine, the less compliance there is. So monticulist being 1 time a day is why that one is prescribed the great majority of the time. I've never prescribed the other one. They are really good to prevent exacerbations. It needs to be taken on a regular basis. It doesn't have an acute response. It's something that's built over time because it makes blocking those leukotrienes, and it's really good if used if there's an aspirin-induced asthma, which can happen. Before we talk about this slide, your text again has a great nursing process on bronchodilators, and then there's another nursing process for these leukotriene receptor agonists. There's a section, there it is, prototype drug chart 41.2 on page 594, which goes over the montelukast more, which is the very common one. I'd be very familiar with that one. So here we go to glucocorticoids, which are the steroids. We talked about them in the form in the nasal. It can also be taken orally or inhaled through a multi-dose inhaler. It can be given IV. It can be combined with other drugs, as noticed here in some of the inhalers. They'll be with a short or long-acting beta-2 agonist combined with the steroid to give better management. It reduces these glucocorticoids, reduce the bronchial hypersensitivity, and give a better response than just the beta-2 agonist alone. It is preferred to do the inhaled, but sometimes you have to do the oral doses. Biggest teaching to remember is can cause this throat irritation, hoarseness, dry mouth. It's usually localized when you're doing it by inhaler. Most important teaching, if anybody is using an inhaler that has a steroid in it, they need to rinse their mouth after each time they use the inhaler to decrease the chances of getting the yeast or the thrush in the mouth. Page 596 has the stepwise treatment for asthma. That is beyond what we're going to get into here, but you can just look and see where all these different medicines we spoke about are added in at different points for management of asthma. Cromolyn used to be used quite often, not so much anymore because they have other measures to use. It's a prophylactic treatment, which means it is not to be used for an acute attack. It has to be used daily, cannot miss doses on it. The way it works is not to dilate, but to block that histamine response to prevent the attack from coming on. It is used in an inhaler. It can cause a cough, a bad taste, rebound bronchospasms if stopped abruptly. That's why you want to tell them to use it every day. That's why with all their problems, it's where it's not really used that often. Side effects, throat irritation, cough, mouth dryness, chest tightness, wheezing, sometimes a reversible dermatitis, which is an inflammation or rash on the skin. Gastroenteritis, multiple side effects, so it's not a favored drug, not one that you will see used that often anymore. I liked Cromolyn when it used to come in a nasal, and it worked really well for the local hay fever, but I don't know that it's on the market anymore in that form, and it's not in your text, so it may be off the market. Metacromyl, it's pretty much the same thing, used the same way as the Cromolyn, and I have actually never heard of this one, so I wouldn't really worry about. It says it's believed to be more effective than Cromolyn, but I have never seen this, and I guess it is listed on your asthma thing, but you figure most kids that are getting this management, most of them are children with the bad taste and the side effects and the bronchospasms. When you have other options, it's unlikely you're going to get somebody to use this. Okay. Drug therapy for asthma according to age. That's again in your chart, in your text. Mucolytics. As you can see, it says it liquefies and loosens the thick mucus secretions. It is given by a nebulizer. It's never given mixed with anything else. I've not seen people doing this at home, although it could be. I've seen it administered in the hospital. You will know if your patient is getting it because it smells like rotten eggs. It is exactly what it smells like. It's an awful smell when they're getting that treatment. And never add that with another respiratory medication. It must be given by itself. And I have given Mucomyst or acetylcysteine, generic name, as an antidote for acetaminophen overdose. It has to be given within 12 to 24 hours of that overdose taking place. This other Dornase alpha is not one I've ever administered. It's for that used for cystic fibrosis because they get the most awful thick secretions, but you'll learn more of cystic fibrosis when you get into pediatrics. So that's what that one is used for. And that is end of chapter 41.